Ever feel like you're drowning in cardiology research?
Oh, yeah. I mean, it's like every day there's another trial popping up
Yeah,
and trying to stay on top of it all.
it's a lot.
It's a Herculean task.
But that's why we're here,
Yeah, he's
to
lawyer.
take on that mountain of trials
Yeah.
and figure out what the really juicy bits are.
Pull out the really impactful findings.
Yeah, and how does it actually impact patient care?
Absolutely.
Oh,
I think
okay.
that's the key thing.
And a huge thank you to London Heart Beats the Academy
Yes.
in the UK for their incredible support in making this deep dive happen.
They've been instrumental.
If you are looking to level up your cardiology game, they've got over 150 awesome courses.
It's an amazing resource.
And trust me, you don't want to miss their regular free updates on Facebook, Instagram, and YouTube.
Definitely check them out.
So hit that subscribe button and let's dive in.
Let's do it.
Okay, so
It's really fascinating to see how these trials spanning decades of research have shaped the very foundation of modern cardiology. I mean, they've influenced everything from the medications we prescribe to the procedures we perform.
Yeah.
And ultimately impacting the lives of countless patients.
it's like having a backstage pass to the evolution of cardiology.
Exactly.
So let's kick things off with a group of medications that has really made a splash in heart failure treatment.
Right.
ARNI,
ARNI. Okay.
or angiotensin receptor neprilysin inhibitors.
A mouthful,
I know.
but important medications.
So ARNIs are quite intriguing because they're not just one drug,
Right.
but a combination of two.
Accommodations.
The cubitril, which enhances the body's natural protective mechanisms,
Kind of boosts the good stuff.
and valsartan, which blocks harmful pathways.
Right, so it gets rid of the bad stuff.
This dual action makes them a really powerful force in heart failure management.
It does, and it's really revolutionized the way we approach heart failure.
And speaking of powerful forces, one trial that really shook things up was the Paradigm-HF trial,
Oh, yes, Paradigm-HF.
published in 2014.
Huge trial.
Huge trial.
Really a landmark trial.
So
This trial was a real eye-opener.
it pitted ARNI against an alloprol, an ACE inhibitor that was considered the gold standard at the time,
It was the top dog.
in patients with heart failure, with reduced ejection fraction, or HFrEF,
Right.
and the results were pretty astounding.
Yeah, they were.
The ARNI group showed a significant reduction in both cardiovascular deaths and heart failure hospitalizations.
It really outperformed enalapril by a significant margin.
This trial basically turned the cardiology world on its head,
It did. It was a paradigm shift.
making ARNI the new go-to therapy for many HFrEF patients.
Absolutely. For many patients, it became the first-line treatment.
It's amazing how one trial can completely change the treatment landscape.
It really can.
And then there's the Pioneer-HF trial from 2019, which took on the challenge of using RNI in patients hospitalized with acute decompensated heart failure.
Right. So these are really sick patients who are coming in with acute heart failure.
Timing is everything in acute heart failure. And this trial addressed a crucial question.
Hmm?
Is it safe and effective to start ARNI right there in the hospital?
Right on admission.
Turns out it is.
Yes.
Pioneer-HF showed that early initiation of RNI, even during those critical moments of hospitalization, was beneficial.
It made a difference. It improved outcomes.
So another win for ARNI.
Absolutely.
But heart failure with preserved ejection fraction, or HFpEF, has always been a tough nut to crack.
Oh, it has.
And that's where the Paragon-HF trial from 2019 came in.
Okay, Paragon-HF.
Okay.
HFpEF has been a real puzzle for cardiologists,
Yeah.
with very limited treatment options showing consistent benefit.
Yeah.
Paragon-HF investigated whether ARNI could make a difference in this challenging patient population.
So,
And while it didn't show a significant impact on mortality,
okay.
it did reduce heart failure hospitalizations,
Okay.
especially in patients with mildly reduced ejection fraction.
Oh,
So that gray area between preserved and reduced,
that in-between area.
the in-between areas,
Okay.
so it wasn't a complete home run. Not a complete home run.
But it did offer some hope
It offered a glimmer of hope
for select HFpEF patients.
for a subset of those patients.
Progress, even if it's incremental, is still progress.
Absolutely. We'll take any progress we can get in HFpEF.
And then we have Paradise-May, a more recent trial published in 2022, which explored the use of IRNI after a heart attack to reduce future cardiovascular events.
Right, so secondary prevention after a heart attack. This trial added another piece to the IRNI puzzle. May suggested benefits,
Okay.
but mainly in specific subgroups of patients after a heart attack,
Oh.
highlighting the importance of personalized medicine.
Yeah.
It didn't lead to widespread adoption of ARNI for every post-MI patient.
Okay.
But it did spark important conversations about tailoring treatment based on individual risk factors.
It seems like personalization is becoming increasingly important in cardiology.
Absolutely.
And rounding out our RNI deep dive is the PREVE-HF trial from 2019, which took a closer look at how RNI affects the heart structure and function over time.
So this was looking at the long-term effects of ARNI. This trial provided some really encouraging real-world evidence.
Okay.
It showed that ARNI not only improves symptoms,
Yeah.
but can actually reverse some of the negative remodeling that happens to the heart in heart failure.
Wow.
So it's not just treating the symptoms.
Yeah.
It's actually modifying the disease process.
That's actually changing the heart.
It is.
So it's not just about treating symptoms, it's about modifying the disease process itself.
Exactly.
Now let's shift our focus to another group of medications that has revolutionized cardiology. Beta blockers.
Oh, the beta blockers.
They've been around for a while,
Been around for a while.
but they've really earned their place in heart failure treatment.
Absolutely.
So beta blockers have a fascinating history.
They do.
They essentially work by calming down the heart.
Just slowing the heart rate down.
But there was a time when they were actually thought to be harmful in heart failure.
I know, it's hard to believe now.
Thankfully, landmark trials like MERIT-HF completely changed that perception.
They really turned things around.
So MERIT-HF, published in 1999, really put beta blockers on the map for heart failure.
That's right.
It focused on metoprolol in patients with HFrEF and demonstrated a significant reduction in both all-cause mortality and cardiovascular mortality.
It really showed that beta blockers could save lives in heart failure.
It's amazing how research can turn conventional wisdom on its head.
It's true. It challenges our assumptions and sometimes leads to major breakthroughs.
And then we have the Copernicus trial published in 2001, which took on the challenge of treating patients with severe heart failure.
Right, so these are the really sick patients.
It showed that even in those with advanced disease carvedilol, another beta blocker was safe and effective at reducing mortality and hospitalizations.
It expanded the use of beta blockers to a wider range of patients.
So beta blockers became a mainstay even in those really sick patients.
It became part of the standard of care.
And let's not forget the SBIS-2 trial from 1999, which studied bisoprolol, yet another beta blocker in heart failure.
Right. SBIS-2 added another piece of evidence to the growing body of research supporting beta blockers.
Yeah.
It showed that bisoprolol also effectively reduced all-cause mortality and hospitalization rates in heart failure patients,
Okay.
further solidifying its place as a cornerstone therapy.
So we've got metoprolol, carvedilol, and bisoprolol, a trio of beta blockers proving their worth.
The three musketeers of beta blockers.
Interestingly, one of the earliest trials to show carvedilol's benefits in milder forms of heart failure was the U.S. Carvedilol-HF trial, way back in 1996.
That was a pioneering trial.
So
It paved the way for the inclusion of carvedilol in heart failure guidelines, particularly for patients with earlier stage disease.
expanding the use of beta blockers beyond just those with severe heart failure.
Exactly.
Another win for carvedilol.
Absolutely.
But it's important to remember that not all beta blockers are created equal.
Right.
The BEST trial from 2001, which looked at bucindolol in advanced heart failure, is a good example of that.
Okay, BEST. BEST showed a trend towards mortality reduction with bucindolol,
Yeah.
but it didn't quite reach statistical significance.
Oh, because it didn't really take off.
It didn't really take off.
So some beta blockers shine brighter than others.
Some are more effective than others.
Now, the COMET trial, published in 2003, directly compared carvedilol and metoprolol in chronic heart failure.
Oh, head-to-head matchup.
Head-to-head matchup.
Yeah, carvedilol versus metoprolol.
Some-
COMET was a real showdown. It showed that carvedilol was actually more effective at reducing mortality than metoprolol tartrate.
Wow. So carvedilol won,
Carvedilol emerged victorious.
giving it an edge in many clinical guidelines.
It became the preferred beta blocker in many cases.
This trial highlighted the importance of head-to-head comparisons to truly understand the comparative effectiveness of different therapies.
Absolutely.
So in the battle of the beta blockers, carvedilol emerged victorious.
That's right.
Now, the SHIFT trial from 2010 took a slightly different approach, focusing on heart rate reduction in patients who were already taking beta blockers but still struggling with a fast heart rate.
So these are patients who are already on maximally tolerated doses of beta blockers, but their heart rate is still too high.
Yeah.
And that can be a problem.
Yeah, so.
Shift introduced a medication called ivabradine,
Okay.
which works in a unique way to slow down the heart rate.
So it's not a beta blocker.
It's not a beta blocker.
Right.
It works through a different mechanism.
Yeah.
The trial showed that adding ivabradine to beta blocker therapy
Yeah.
could improve outcomes in these patients.
It was like an add-on.
An add-on therapy.
It led to stronger recommendations for using ivabradine in combination with beta blockers for those with symptomatic heart failure and elevated heart rates.
It became part of the guidelines.
So even when the patients are on beta blockers, there's still room for optimization.
Absolutely.
And then there's BB-META-HF, a massive meta-analysis published in 2013 that combined data from multiple beta blocker trials in heart failure.
Right. A meta-analysis is a way of pooling data from multiple studies to get a more robust estimate of the effect.
It wasn't a single trial, but a powerful synthesis of evidence.
A really comprehensive analysis.
Sure.
BB-META-HF was a tour de force.
Yeah.
It confirmed the consistent benefits of beta blockers in heart failure.
Yeah.
Regardless of which specific beta blocker was used.
So across the board.
Across the board.
It provided an even stronger evidence base for their universal use in heart failure guidelines.
It solidified their place in the guidelines.
Okay, so beta blockers have truly earned their stripes in heart failure treatment.
Yeah, they're a cornerstone of therapy.
Now let's talk about another group of medications that has taken the cardiology world by storm. SGLT2 inhibitors.
SGLT2 inhibitors, yeah.
These medications were initially developed for diabetes.
For blood sugar control.
But they've proven to have impressive benefits for the heart, even in patients without diabetes.
It's really remarkable how a class of drugs that was initially intended for one condition can have such profound implications for another.
Yeah, so the DAPA-HS trial, published in 2019, was a real game changer in this regard.
It was a pivotal trial.
So,
DAPA-HF looked at dapagliflozin, an SGLT2 inhibitor, in patients with HFrEF, and found that it significantly reduced both cardiovascular deaths and heart failure hospitalizations.
Yeah.
Regardless of whether the patient had diabetes or not.
That's huge.
It was game changer.
This trial completely changed how we view SGLT2 inhibitors, making them a cornerstone therapy for heart failure regardless of diabetes status.
It really expanded the use of these medications.
It's like they broke free from their diabetes shackles.
They did. They became much more widely used.
And then we have the Emperor Reduce trial, published in 2020, which studied another SGLT2 inhibitor, empagliflozin, in HFrEF. So
the results mirrored those of DAPA-HF. Further strengthening the evidence for SGLT2 inhibitors in heart failure treatment.
For two major trials, two different SGLT2 inhibitors, same impressive results.
Remarkable consistency.
It's like they were trying to outdo each other.
A friendly competition.
Now, the Soloist WHF trial, published in 2021, focused on patients recently hospitalized for worsening heart failure.
So these are patients who are recovering from an acute heart failure episode.
Yeah.
This trial investigated sotagliflozin, yet another SGLT2 inhibitor.
Another one.
Yeah, and found that it significantly reduced cardiovascular deaths and heart failure hospitalizations in patients with both HFrEF and HFpEF. This expanded the potential applications of SGLT2 inhibitors to include both types of heart failure.
Oh, wow.
Even in the post-hospitalization setting.
Wow, so even after a heart failure hospitalization, SGLT2 inhibitors can make a difference.
They can.
But, as we mentioned before, HFpEF has been a particularly challenging form of heart failure to treat.
It's a tough one.
The Emperor Preserve trial, also from 2021, took on that challenge head-on.
It did. So this trial was a landmark study because it was the first to demonstrate the efficacy of any therapy in reducing heart failure hospitalizations in patients with HFpEF, regardless of diabetes status.
Wow.
It finally offered some hope for these patients and led to the recommendation of SGLT2 inhibitors for HFpEF in updated guidelines.
It's incredible to witness such a breakthrough for a condition that has stumped cardiologists for so long.
It was a major victory.
Now, the Deliver trial, published in 2022, provided even more robust evidence for SGLT2 inhibitors in HFpEF.
Right. Deliver really solidified their role.
Further solidifying their role in managing this condition.
Absolutely.
Yeah.
The liver expanded the potential patient population who could benefit from SGLT2 inhibitors,
Yeah.
showing that dapagliflozin significantly reduced heart failure hospitalizations across the entire spectrum of preserved ejection fraction.
So SGLT2 inhibitors are making waves in both HFrEF and HFpEF.
They're a force to be reckoned with.
But it's not just about survival and hospitalizations.
Right.
The DEFINE-HF trial from 2020 looked beyond those hard endpoints.
Yeah, mortality and hospitalizations.
To examine the impact of dapagliflozin on symptoms and quality of life in patients with HFrEF.
So looking at the patient experience, DEFINE-HF revealed something quite remarkable. Dapagliflozin not only improved survival and reduced hospitalizations,
Yeah.
but also led to improvements in health status,
Wow.
quality of life,
Okay.
and even biomarkers related to heart failure severity.
So it's like a triple whammy.
It is.
This trial really put the spotlight on the patient-centered benefits of SGLT2 inhibitors, encouraging their use not just to prolong life, but to improve its quality.
Absolutely. It's not just about living longer, it's about living better.
It's all about giving patients their lives back.
Exactly.
Now, to understand the full impact of SGLT2 inhibitors, we need to step back in time a bit.
Okay, let's go back in time.
The Kansas trial from 2017, which focused on canagliflozin in patients with diabetes and cardiovascular risks, was one of the first to hint at their broader cardiovascular benefits.
So this was kind of the first clue that these medications might have benefits beyond blood sugar control.
What?
Canvas demonstrated a reduction in heart failure hospitalization and improved renal outcomes in these patients, sparking a wave of cardiovascular research into SGLT2 inhibitors that ultimately led to the groundbreaking trials we've just discussed.
So it was like a domino effect.
It was.
It was a key study that laid the groundwork for the SGLT2 inhibitor revolution.
It was a pioneer.
It's like Canvas was the spark that ignited a firestorm of research.
A great analogy.
And then there's the DECLARE-TIMI-58 trial from 2019, which also looked at dapagliflozin in patients with diabetes and cardiovascular risks.
Okay.
So
DECLARE-TIMI-58 further supported the dual cardiovascular and renal benefits of SGLT2 inhibitors, showing that dapagliflozin could reduce heart failure hospitalizations and improve renal outcomes, influencing guidelines to consider diabetes status in heart failure management.
So a common thread emerges.
Yeah.
SGLT2 inhibitors benefit both the heart and the kidneys.
They do. They have multiple benefits.
And speaking of benefits, the Heart Feed trial, published in 2022, explored a specific group of heart failure patients, those with iron deficiency.
Right. Iron deficiency is common in heart failure. What's interesting about HeartFight is that it showed that SGLT2 inhibitors provided additional benefits on mortality and heart failure hospitalizations in these patients.
So even in those with iron deficiency.
Exactly.
This expanded the clinical relevance of SGLT2 inhibitors to a broader range of heart failure patients.
It broadened their applicability.
Regardless of complicating factors like iron deficiency.
It showed they could work in a variety of settings.
So even with comorbidities, SGLT2 inhibitors can make a difference.
They can.
And to round out this impressive lineup of SGLT2 inhibitor trials, we have the Preserved HF trial from 2021.
Okay, Preserved HF.
Yeah.
This trial zeroed in on the effects of dapagliflozin on physical function and symptoms in patients with HFpEF.
So again, looking at the patient experience.
Exactly, and the results were remarkable.
Okay.
These patients experienced fewer symptoms, better exercise capacity, and fewer physical limitations.
So it's like they were getting their lives back. This provided crucial patient-centered outcomes data supporting the use of SGLT2 inhibitors in HFpEF, not just for hospitalization reduction, but for tangible improvements in daily life.
It showed they could improve quality of life.
It's like SGLT2 inhibitors are giving patients their lives back.
It's really remarkable.
Okay, so we've covered a lot of ground on ARNI and SGLT2 inhibitors.
We have.
Two relatively new players in the heart failure game.
The new kids on the block.
Now let's step back in time a bit and look at a group of medications with a long and storied history in heart failure treatment. ACE inhibitors?
ACE inhibitors, the pioneers.
So?
ACE inhibitors were real pioneers in the field.
Yeah.
They work by blocking a key enzyme in the body's blood pressure regulation system.
Yeah.
And they've been studied extensively in heart failure.
And one of the earliest and most impactful trials in this area was the Consensus trial, published back in 1987.
Consensus, a classic.
It looked at enalapril, an ACE inhibitor in patients with severe heart failure, and demonstrated significant reductions in mortality.
It was a breakthrough.
This was a groundbreaking moment because before Consensus, There weren't many effective treatments for heart failure.
There weren't many options at all.
It really ushered in the era of ACE inhibitors as the first choice therapy for this condition.
It changed the landscape of heart failure treatment.
It's amazing to think how far we've come since then.
It really is.
Consensus was a true turning point.
A landmark trial.
And then we have the SLVD treatment trial from 1991, which focused on enalapril in patients with symptomatic heart failure and reduced ejection fraction.
Right.
This trial further solidified ACE inhibitors as a cornerstone therapy, showing that enalapril not only reduced mortality, but also improved quality of life by reducing heart failure hospitalizations.
It showed they could improve both quantity and quality of life.
So ACE inhibitors were becoming the standard of care for HFrEF.
They were.
But the SLVD prevention trial, published in 1992, took a slightly different approach.
Right.
It looked at enalapril in patients who were either asymptomatic or only had mild symptoms,
Okay.
but had left ventricular dysfunction.
So they had some evidence of heart damage, but weren't necessarily experiencing symptoms yet.
Yeah.
SLVD prevention was a fascinating trial because it focused on prevention rather than treatment.
Yeah.
It found that enalapril could actually delay the onset of symptomatic heart failure and reduce the number of heart failure hospitalizations in these at-risk patients.
It was like nipping it in the bud.
Exactly.
This supported the use of ACE inhibitors not just in those with active heart failure,
Yeah.
but also in those at risk of developing it.
A preventative strategy.
A proactive strategy to prevent the progression of the disease.
Absolutely.
It's like catching heart failure before it fully develops.
Early intervention is key.
Now, the SAVE-E trial from 1992 studied captopril, another ACE inhibitor, in patients who had a heart attack and also had left ventricular dysfunction.
Okay, so post-heart attack.
Yeah.
The results of SAVE-ER were quite striking.
Yeah.
Captopril significantly reduced all-cause mortality, the development of heart failure and cardiovascular deaths in these patients. This trial broadened the use of ACE inhibitors to include the post-heart attack setting, offering significant protection to those at high risk of developing heart failure.
So another important application for ACE inhibitors.
It expanded their use.
And the evidence just kept building.
It did.
The TRACE trial from 1995 investigated trandelapril, another ACE inhibitor, in patients with a heart attack and left ventricular dysfunction,
Right.
echoing the findings of SAVE and further reinforcing the role of ACE inhibitors in post-heart attack management.
It provided further support for their use.
Oh.
TRACE added another piece to the puzzle,
Yeah.
showing that trandelapril also reduced both all-cause and cardiovascular mortality, strengthening the guidelines for post-MI care to include ACE inhibitors as a way to improve survival.
It's like these trials were building a fortress of evidence around ACE inhibitors.
A solid foundation.
And the ARNI trial from 1993 provided even more support, confirming the benefits of ramipril, another ACE inhibitor, in patients showing signs of heart failure after a heart attack.
Right. ARAC added another brick to that fortress,
Yeah.
showing a significant reduction in mortality and further supporting the guidelines for post-MI care to include ACE inhibitors.
Okay, so ACE inhibitors were clearly a game changer in heart failure and post-MI care.
They were a major breakthrough.
But what about dosing?
Dosing.
The ATLA's trial from 1999 took on the challenge of determining the optimal dose of lisinopril, another ACE inhibitor, in patients with HFrEF.
Okay, so ATLAS was an important trial because it tackled the question of whether more is always better when it comes to ACE inhibitor dosing.
Right.
And it found that higher doses of lisinopril did lead to greater reductions in hospitalizations,
Yeah.
but they didn't offer any additional mortality benefit.
Oh.
So there was a ceiling effect.
This helped to refine dosing strategies for ACE inhibitors, striking a balance between effectiveness and potential side effects.
It helped to optimize therapy.
So finding that sweet spot for dosing is crucial.
It is.
But the Hayes trial, published in 2000, took things a step further. It looked beyond just heart failure patients and studied ramipril in a broader group of individuals considered to be at high risk for cardiovascular events.
So expanding the population.
Yeah.
HOPE-PE was a landmark trial because it highlighted the broad cardiovascular benefits of ACE inhibitors,
Okay.
extending beyond just blood pressure lowering to include overall cardiovascular protection.
So it wasn't just about the blood pressure.
It was about more than that.
It showed that ramipril could reduce rates of cardiovascular death, heart attack, and stroke, even in those without heart failure.
Wow.
This really influenced strategies for preventing heart failure and other cardiovascular events, expanding the potential applications of ACE inhibitor.
It broadened their scope.
So even without heart failure, ACE inhibitors can offer protection.
They can.
But what about combining them with other heart failure medications?
Yeah, okay. Combination therapy.
The CIBIS trial, published in 1994, provided some answers.
Right.
It looked at the use of bisoprolol, a beta blocker, in patients with HRAF.
Right.
Now, we've already talked about beta blockers.
We have.
But this trial was particularly relevant to ACE inhibitors.
Okay. CBIS confirmed the combined benefits of using ACE inhibitors and beta blockers together.
Yeah.
It showed that this combination therapy was even more effective at reducing heart failure mortality than either medication alone.
Okay.
So 1 + 1 = 3 in this case.
It really reinforced the guideline recommendations for using ACE inhibitors as foundational therapy, often in combination with beta blockers, a powerful duo in the fight against heart failure.
A dynamic duo.
So teamwork makes the dream work.
It does.
Now, the Europa trial, published in 2003, focused on perindopril, another ACE inhibitor, in patients with stable coronary artery disease, but without heart failure.
Okay, so coronary artery disease, but no heart failure.
So,
Europa highlighted another important application of ACU inhibitors.
yeah.
It showed that perindopril significantly reduced both cardiovascular deaths and hospitalizations in these patients, further solidifying its role in cardiovascular risk reduction, complementing its role in preventing heart failure in patients with stable coronary artery disease.
It seems like ACE inhibitors have a knack for exceeding expectations.
They do their versatile medications.
Okay, so we've covered a lot of ground with ACE inhibitors,
We have
the trailblazers of heart failure treatment.
the pioneers.
Now let's move on to another group of medications that are closely related to ACE inhibitors, angiotensin receptor blockers, or ARBs.
ARBs, all right. ARBs work in a similar way to ACE inhibitors,
Yes.
blocking the effects of a hormone called angiotensin II,
Sure.
which plays a key role in blood pressure regulation and various cardiovascular processes.
And they've also been studied extensively in heart failure,
They have.
offering a valuable alternative for patients who can't tolerate ACE inhibitors.
Right, for those who have side effects from ACE inhibitors.
One of the earlier trials in this area was ELITE, published in 1997.
Elite, okay.
It compared losartan, an ARB, to captopril, an ACE inhibitor in elderly patients with heart failure.
So head-to-head again.
Okay.
Elite suggested that losartan was just as effective as captopril in reducing mortality and hospitalizations in this older population,
Okay.
but it was better tolerated,
Ooh.
highlighting ARBs as a potential alternative for patients who couldn't handle the side effects of ACE inhibitors.
So a new option for those who might struggle with side effects.
Exactly.
And the ELITE 2 trial, published in 2000, confirmed those findings, further solidifying ARBs as a viable substitute for ACE inhibitors in those who couldn't tolerate them.
It provided further support.
So-
Elite 2 really cemented the role of ARBs as a valuable alternative, offering comparable efficacy with a potentially better side effect profile.
A win-win.
It was a win for patients who needed another option.
Absolutely.
Yeah.
Now, the CHARM overall trial from 2003 was a major study that looked at candesartan, another ARB, in a wide range of heart failure patients,
Okay, CHARM overall.
including those with both reduced and preserved ejection fraction.
So both HFR-EF and HFPEF. CHARM overall was a significant trial because it expanded the use of ARBs to a broader spectrum of heart failure patients.
Yeah.
It showed that candesartan reduced cardiovascular deaths and heart failure hospitalizations in both HFR-EF and HFPEF,
Wow.
making it a key treatment option for a wider range of patients.
It's like they were pushing the boundaries of heart failure treatment.
They were.
But could ARBs offer additional benefits when added to existing ACE inhibitor therapy?
Interesting question.
The CHARM-added trial, also from 2003, explored that question in patients with HFrEF.
Okay. CHARM-added revealed that adding candesartan on top of an ACE inhibitor
Okay.
further reduced both heart failure hospitalizations and cardiovascular deaths.
Oh, wow.
So there was an additive benefit.
This highlighted the potential for additive.
This highlighted the potential for additive benefits of combining these two classes of medications even when patients were already on an ACE inhibitor. Sometimes two is better than one.
Exactly. But HFpEF, as we've discussed, has always been a challenge.
Yeah.
Could ARBs make a difference in this difficult-to-treat group? The CHARM Preserve trial, also from 2023, aimed to find out.
Okay. CHARM Preserved.
So,
CHARM Preserved focused specifically on patients with HFpEF and investigated whether candesartan could improve outcomes.
okay.
And while it didn't show a significant impact on mortality,
Okay.
it did find a modest reduction in heart failure hospitalizations with candesartan.
So a little bit of a signal there.
A little bit of a signal.
This provided some support for using ARBs in HFpEF.
Yeah.
But the benefit was less pronounced than in HFpEF.
It was a smaller effect.
The trial's findings influenced guidelines to recommend ARBs for HFpEF, but with a more cautious and selective approach.
A bit more nuanced.
So a step in the right direction for HFpEF, but still a work in progress.
Still room for improvement.
Now, the VLHEF trial from 2001 assessed valsartan, another ARB, in HFrEF, both with and without background ACE inhibitor therapy.
Okay, VLHEF provided further support for the use of ARBs in heart failure.
Okay. It found that valsartan reduced heart failure hospitalizations in these patients.
Okay.
But it didn't provide any additional mortality benefit when added on top of an ACE inhibitor.
So no added benefit on top of the ACE inhibitor.
Now, in terms of mortality.
This supported the use of ARBs, especially as a substitute for or in addition to ACE inhibitors in patients who couldn't tolerate them.
Right, as an alternative.
So reinforcing that idea of ARBs as a valuable alternative.
Exact.
But how did ARBs stack up against ACE inhibitors in the post-heart attack setting? The optimal trial from 2002 compared losartan to captopril in patients who had both a heart attack and heart failure.
Another head-to-head.
Another head-to-head. Okay.
Okay.
Optimal provided a reality check,
Okay.
showing that in this specific scenario, losartan wasn't as effective as captopril in reducing mortality. This reinforced the position of ACE inhibitors as the first-line therapy in the post-heart attack setting, with ARBs reserved for those who couldn't tolerate them.
So ACE inhibitors still held the edge in certain scenarios.
They did in that particular setting.
But what about optimizing ARB dosing? The HEAL trial from 2009 investigated different doses of losartan in HFrEF.
Okay. HEAL.
Oh.
HEAL provided valuable insights into dosing strategies for ARBs.
Okay.
It found that higher doses of losartan were more effective at reducing both heart failure hospitalizations and mortality
Okay.
compared to lower doses.
So higher dose, better outcome?
In this case, yes.
This highlighted the importance of finding the right dose to achieve the best outcomes.
Dose optimization is crucial.
So another reminder that dosing matters.
It does.
And speaking of timing, the titration trial from 2015 focused on the timing of ARB initiation and dose adjustment in heart failure patients.
Okay, titration.
So,
Titration demonstrated that it was safe and effective to start ARBs early
okay.
and to adjust the dose upward relatively quickly to reach an optimal level.
So no need to dilly-dally.
Get to the right dose as quickly as possible.
This supported recommendations for timely and appropriate titration of ARBs in these patients.
It helped to refine our dosing strategies.
So getting the right dose as quickly as possible is key.
It is.
Okay, we've covered a lot of ground with medications that target blood pressure and other aspects of heart failure. Now let's shift our focus to a medication that specifically targets heart rate. Ivabradine.
Ivabradine, all right.
Check.
Ivabradine works in a unique way by selectively slowing down the heart rate, offering an alternative or complementary approach to beta blockers.
So it's not a beta blocker.
It's not a beta blocker. It works through a different mechanism.
And it's been studied extensively in heart failure,
It has.
particularly in patients who still have elevated heart rates despite being on beta blocker therapy.
Right. So for those who aren't achieving adequate heart rate control with beta blockers.
And one of the most important trials in this area is this SHIFT trial from 2010, which we touched on earlier when discussing beta blockers.
Yes. SHIFT was a pivotal trial for Ivabradine.
Oh, okay.
It showed that adding Ivabradine to beta blocker therapy could improve outcomes in patients with HFrEF who had elevated heart rates,
Yeah.
despite being on beta blockers.
So they were already on beta blockers,
They were.
but still had high heart rates.
Right. Their heart rate was still too fast.
This led to its inclusion in heart failure guidelines,
Yeah, it became part of the standard of care
particularly for those with persistent high heart rates.
for that specific subset of patients.
So another tool for fine-tuning heart rate control.
Absolutely.
But what about Ivabradine in patients with stable coronary artery disease and left ventricular dysfunction? The beautiful trial from 2008 explored that question.
Okay, beautiful. Beautiful found that Ivabradine didn't reduce mortality in these patients,
Okay.
but it did show a reduction in hospitalizations for angina in those with higher heart rates.
So a benefit for angina.
Yes, for angina.
This highlighted Ivabradine's potential benefit in select patients with coronary artery disease and fast heart rates,
Right.
but it didn't lead to widespread recommendations for this group.
It remained a niche indication.
So a niche benefit, perhaps.
Hmm.
But what about patients with stable coronary artery disease but without heart failure?
Ooh.
The Signify trial from 2014 investigated Ivabradine's role in this population.
Okay. Signify.
Nah.
Unfortunately, Signify didn't show any mortality or cardiovascular benefit with ivabradine in these patients. And it actually raised concerns about bradycardia or slow heart rate.
Oh, so it could actually slow the heart rate down too much.
It could in some cases.
This led to more restricted recommendations for ivabradine, limiting its use primarily to heart failure patients with reduced ejection fraction and high heart rates.
Right. It narrowed its use.
So highlighting the importance of using the right medication for the right patient.
Absolutely.
Now, SHIFT-ECHO, a sub-study of the original SHIFT trial, provided some interesting insights into ivabradine's effects on cardiac remodeling or the changes that happen to the heart structure over time in heart failure.
So this was looking at whether ivabradine could actually improve the heart structure.
Okay.
SHIFT-ECHO found that ivabradine could actually improve left ventricular function and reduce the negative remodeling process in those with elevated heart rates.
So it's not just about the symptoms.
It's about more than that.
It's actually changing the heart.
It is.
This reinforced ivabradine's role in improving not just symptoms, but also the underlying heart structure, further supporting its use in heart failure guidelines.
It strengthened its position in the guidelines.
So it's not just about treating symptoms, it's about addressing the underlying disease process.
Exactly.
Now, the EPIC-AHF trial from 2019 looked at ivabradine in a different setting. Patients with acute decompensated heart failure.
Okay, EPIC-AHF.
Yeah.
EPIC-AHF showed that ivabradine could improve symptoms and reduce levels of NT-proBNP, a key biomarker in these patients.
Okay.
While this generated some discussion about ivabradine's potential role in acute heart failure, it hasn't yet been widely incorporated into guidelines for this specific scenario.
So more research is needed.
More data is needed.
To solidify its place in acute heart failure.
To confirm its role.
But what about its impact on hospital readmissions? The REDUCTION trial, published in 2017, examined ivabradine's role in reducing readmissions in heart failure patients.
Okay, REDUCTION.
So,
REDUCTION provided some encouraging results showing that ivabradine significantly reduced both heart failure readmissions and improved patient quality of life.
So fewer readmissions and better quality of life.
That's what we like to see.
This strengthened the evidence for using ivabradine to not just stabilize patients, but also to keep them out of the hospital and improve their overall well-being.
Absolutely.
That's what we like to hear. A medication that helps patients stay healthy and out of the hospital.
Exactly.
And the PRIME-HF trial from 2020 further supported the guideline recommendations for using ivabradine.
Right.
Particularly in those with persistent symptoms and elevated heart rates, despite being on beta blockers.
For that specific group of patients, PRIME-HF demonstrated that adding ivabradine to standard therapy led to better heart rate control and symptom relief in these patients.
It's like fine-tuning the engine.
It is.
It was another reminder that sometimes fine-tuning therapy can make a real difference in patients' lives.
It can?
Absolutely. And speaking of making a difference, the ACTIVATE trial from 2013 focused specifically on ivabradine's effects on exercise tolerance in heart failure patients.
Okay, ACTIVATE.
So,
ACTIVATE showed that ivabradine could actually improve exercise capacity.
Wow.
And reduce heart rate during exercise.
So they could do more.
They could.
These benefits translated into real improvements in quality of life for these patients, allowing them to engage in physical activity more easily.
Right. It helped them get back to doing the things they enjoyed.
It's all about helping patients live their lives to the fullest.
Absolutely.
Okay, so we've covered a lot of ground with traditional heart failure medications. Now let's explore some of the newer drugs that have emerged in recent years.
The novel therapies.
Yeah.
The world of heart failure treatment is constantly evolving.
Always something new.
There's always something new on the horizon.
And it's exciting to see how these novel therapies are shaping the future of cardiology.
It is.
One of the newer drugs that has garnered a lot of attention is vericiguat, a soluble guanylate cyclase stimulator. Yeah. What exactly does that mean, and how does it work in heart failure?
Okay, so vericiguat works in a rather unique way.
Okay.
It enhances the body's natural pathways that promote vasodilation, or the widening of blood vessels.
Okay.
This can help improve blood flow and reduce the strain on the heart, which is particularly beneficial in heart failure.
So it's like opening up the pipes.
It is like that.
And the key trial that really put vericiguat on the map was Victoria, published in 2020. It looked at vericiguat in patients with HF-ref who were at high risk of hospitalization. What did it show?
Okay, Victoria. Yeah. Victoria provided some interesting insights into vericiguat's potential.
Okay.
While it didn't have a huge impact on mortality,
okay,
it did significantly reduce heart failure hospitalizations in these high-risk patients.
So it kept them out of the hospital.
It did.
This led to its recommendation as an add-on therapy for select patients with advanced heart failure who are still struggling despite other treatments.
Right, for those who need an extra boost.
So another option for those who need extra help.
Exactly.
Now let's talk about omecamtiv mecarbil, a myosin activator, which sounds pretty complex.
It does sound complex.
What is it and what does it do?
So omecamtiv mecarbil works in a fascinating way.
Okay.
It directly targets the heart muscle,
Okay.
enhancing its ability to contract,
Yeah.
which can be helpful in certain types of heart failure.
So it makes the heart squeeze harder.
In a way, yes.
And the pivotal trial here was GALACTIC-HF, published in 2021.
Okay, Galactic-HF, a big trial.
It studied omecamtiv mecarbil in patients with HFrEF and a very low ejection fraction, less than 35%.
Yeah.
What did this trial reveal about omecamtiv mecarbil's potential?
So Galactic-HF showed mixed results.
Okay.
While omecamtiv mecarbil did demonstrate a modest reduction in heart failure events,
Okay.
it didn't have a significant impact on mortality.
They're not a home run.
Not a complete home run.
This led to more limited recommendations for its use, primarily in those with severely reduced ejection fraction and persistent symptoms, despite other therapies.
Right, for a very specific group of patients.
So a potential tool, but with specific applications.
Exactly.
Now, we've already discussed SGLT2 inhibitors in detail, but there's a newer one on the scene. Sotagliflozin, a dual SGLT12 inhibitor. What makes sotagliflozin different from the other SGLT2 inhibitors we've talked about?
Okay, so sotagliflozin essentially blocks the reabsorption of glucose in both the intestines and the kidneys,
Okay.
which leads to lower blood sugar levels and potentially other beneficial effects.
So it works in two places.
It does.
This dual action makes it a unique player in the SGLT2 inhibitor family.
A bit of a different mechanism.
And the key trial that evaluated sotagliflozin in the heart failure setting was SOLOIST-WHF, published in 2021. It looked at sotagliflozin in patients recently hospitalized for worsening heart failure, including those with both HFrEF and HFpEF. What did this trial tell us about sotagliflozin's potential?
So SOLOIST-WHF showed that sotagliflozin significantly reduced both cardiovascular deaths and heart failure hospitalizations in these patients.
Okay.
This highlighted its potential use in the post-acute decompensation setting,
Okay.
and even suggested a broader role in both types of heart failure.
Okay.
However, it's still relatively new,
Yeah.
so it's not yet widely included in guidelines.
So another promising SGLT2 inhibitor to keep an eye on.
Absolutely.
Now let's talk about finerenone, a nonsteroidal mineralocorticoid receptor antagonist, or MRA. What exactly does that mean, and how does it work in heart failure?
Okay, so finerenone blocks the effects of a hormone called aldosterone,
Okay.
which can contribute to fluid retention, inflammation, and fibrosis in the heart and kidneys
Okay.
by blocking aldosterone's harmful effects.
Yeah.
Finerenone can potentially improve outcomes in heart failure patients.
Okay. So it's like a protective agent.
It is, in a way.
And the key trials that evaluated finerenone were Figaro-DKD and Fidelio-DKD, both published in 2021 and 2020, respectively. They looked at finerenone in a specific group of heart failure patients. Those who also had diabetic kidney disease? What does these trials show?
So both Figaro-DKD and Fidelio-DKD showed that finerenone reduced heart failure hospitalizations
Okay.
and slowed the progression of kidney disease in these patients.
So benefits for both the heart and the kidneys.
Exactly.
This led to its recommendation for those with coexisting kidney disease and heart failure, particularly those with diabetes.
Right, a targeted therapy for a specific population.
Now, there's been a lot of buzz around cardiac myosin inhibitors, a newer class of medications that work in a rather unique way.
Cardiac myosin inhibitors, yeah, they're interesting.
How do they work and what conditions are they being investigated for?
They work by inhibiting a protein called myosin,
Okay.
which is involved in heart muscle contraction.
Okay.
The idea is to modulate the force of contraction,
Okay.
which can be beneficial in certain heart conditions such as hypertrophic cardiomyopathy.
HCM. That's a condition where the heart muscle becomes abnormally thick, right?
That's right. The heart muscle gets really big and bulky.
And one of the notable trials in this area was Explorer-HCM, published in 2021. It focused on mavacamten, a cardiac myosin inhibitor in patients with obstructive HCM who are experiencing heart failure symptoms.
Explorer-HCM, a big trial.
Okay.
Explorer-HCM was a significant trial because it demonstrated mavacamten's potential in this challenging condition.
Okay.
It found that mavacamten could improve exercise capacity,
Okay.
reduce the obstruction of blood flow out of the heart,
Okay.
and enhance patients' quality of life.
So a triple win.
It was.
This trial really put mavacamten on the map for obstructive HCM, leading to its emerging role in treatment guidelines.
It became a new treatment option.
So a potential game changer for HCM.
Absolutely.
But what about atrasentan? It's an endothelin receptor antagonist, which sounds pretty complicated.
Yeah.
What exactly does that mean, and what role might it play in heart failure?
So endothelin is a potent vasoconstrictor, meaning it narrows blood vessels. Okay.
Atrasentan works by blocking endothelin's effects, promoting vasodilation and potentially improving blood flow.
So it opens up the blood vessels.
It does.
Which can be helpful in heart failure, particularly in patients with coexisting kidney disease.
Right.
And the key trial that investigated atrasentan was SONAR, published in 2020. It focused on heart failure patients who also had chronic kidney disease. What did SONAR reveal about atrasentan's potential in this specific population?
Okay, so SONAR showed that atrasentan offered renal protection and helped slow the progression of heart failure in these patients, particularly those with diabetic nephropathy.
So a benefit for both the heart and the kidneys.
Exactly.
While it's not yet widely included in guidelines, it does show promise as a potential therapy for managing heart failure with coexisting kidney disease.
It's a promising therapy.
So another potential tool in our arsenal.
There's also been growing excitement around a new class of medications called interleukin-6 inhibitors, specifically ziltivekimab. What can you tell us about this class of drugs and their potential role in heart failure?
So interleukin-6 is a cytokine, a signaling molecule involved in inflammation. In heart failure, chronic inflammation can contribute to disease progression. Ziltivekimab aims to block interleukin-6's effects, potentially reducing inflammation and improving outcomes.
Just like fighting the fire.
Exactly.
And the key trial investigating ziltivekimab is RESOLVE-HF, which is still ongoing, right?
That's right. RESOLVE-HF is ongoing. It's a highly anticipated trial because it's specifically designed to assess ziltivekimab's effects on heart failure outcomes.
Fingers crossed.
We're all hoping for positive results.
Early data suggests it does have anti-inflammatory effects and might reduce heart failure events. But we'll need to wait for the full trial results to draw any firm conclusions.
Right. We need more data.
Fingers crossed for positive results. Now let's talk about niledinis and Biolinit, a partial adenosine A1 receptor agonist. What's the mechanism of action here, and what's the evidence for its use in heart failure?
Okay, so niledinis and Biolinit works by activating a specific type of receptor in the body that can lead to vasodilation and other potentially beneficial effects for the heart.
So another vasodilator.
It is.
And the main trial that investigated niledinis and Biolinate was Pantheon-HF, published in 2019. It looked at niledinis and Biolinate in patients with HFrEF and mild to moderate symptoms. What does this trial show?
Pantheon-HF demonstrated that niledinis and Biolinate could improve exercise capacity and reduce symptoms in these patients. However, it's important to note that the data is still limited. And it's not yet included in any major guidelines.
So it's still early days.
It is.
More research is needed to determine its place in heart failure treatment.
We need more data.
So another one to keep an eye on.
Absolutely.
Okay, we've covered a ton of ground with heart failure medications, both old and new. It's incredible to see how the treatment landscape has evolved over the years.
It's remarkable the progress we've made.
Now let's switch gears and delve into a topic that's crucial in interventional cardiology: fractional flow reserve, or FFR.
FFR, a powerful tool.
So what is it and how does it work?
So FFR is a remarkable technique.
Okay.
It allows us to measure the pressure difference across a coronary artery narrowing, helping us determine whether a blockage is actually limiting blood flow to the heart muscle.
Okay, so it tells us how bad the blockage really is.
It does.
This information is critical in guiding decisions about whether to perform a stent procedure.
Absolutely. It helps us decide who needs a stent and who doesn't.
It's like having a magnifying glass for coronary blockages.
A great analogy.
One of the earliest trials that investigated FFR was DEFER, published in 2001. It assessed the safety of deferring a stent procedure, also known as percutaneous coronary intervention, or PCI, based on FFR.
Okay, DEFER.
So
DEFER was a groundbreaking trial.
Because it showed that not all coronary blockages require immediate intervention. If the FFR was above 0.75, indicating that the blockage wasn't significantly limiting blood flow, PCI could be safely deferred.
So no need to rush into a procedure.
Exactly.
This trial really validated FFR as a reliable measure for determining the significance of a blockage and showed that PCI could be avoided in those with non-ischemic lesions, sparing them from unnecessary procedures and potential risks.
It helped to prevent overtreatment.
So FFR helps us avoid unnecessary intervention.
It does.
But what about when PCI is indicated? The FAME trial, published in 2009, compared FFR-guided PCI to angiography-guided PCI in patients with multivessel coronary artery disease.
Okay, FAME, a classic trial.
So what's the difference between those two approaches?
So FAME was a game changer
Okay.
because it demonstrated the superiority of FFR-guided PCI.
Okay.
The trial found that using FFR to guide PCI significantly reduced the rate of major adverse cardiac events compared to angiography-guided PCI. Okay, so FFR was better.
It was.
Angiography just provides a visual picture of the blockage, while FFR actually measures the impact on blood flow, allowing for more precise and targeted interventions.
It gives us a more functional assessment.
So FFR helps us target the right blockages for stenting.
It does.
And then there's FAME2 from 2012, which took a slightly different approach. It compared FFR-guided PCI to medical therapy alone in patients with stable coronary artery disease.
Okay, FAME2.
So in that trial, were they stenting everybody or just the people who had really bad blockages?
So FAME2 was a thought-provoking trial because it highlighted the importance of medical therapy as a key component of treatment for stable coronary artery disease. While FFR-guided PCI did reduce the need for urgent revascularization, there was no significant difference in mortality or heart attacks between the two groups.
Oh, so medical therapy alone was just as good.
In terms of those hard endpoints, yes.
This trial supported using FFR to guide PCI in stable coronary artery disease. But it also emphasized the importance of a balanced approach that includes optimal medical therapy.
Right, a holistic approach.
So a holistic approach is essential.
It is.
Now, the COMPARE trial from 2009 is focused on a specific type of blockage. Those with intermediate severity, meaning a 50–70% stenosis or narrowing.
Okay, compare intermediate lesions.
So why are those lesions so tricky?
Intermediate lesions can be tricky because it's often difficult to determine just by looking at an angiogram whether they're truly significant. COMPARE found that an FFR of less than 0.80 was highly predictive of future adverse cardiac events. And PCI significantly improved outcomes in these patients.
Okay, so FFR helped to identify those patients who would really benefit from PCI.
It did.
This trial reinforced FFR as a valuable tool for assessing those borderline lesions, helping us make more informed decisions about who needs a stent.
It took the guesswork out of it.
So FFR takes the guesswork out of treatment decisions.
It does.
And speaking of long-term management, the IRIS-FFR trial from 2019 provided valuable long-term follow-up data on patients who had PCI deferred based on FFR.
Okay, IRIS-FFR. IRIS-FFR was essentially a follow-up to the DEFER trial, showing that patients who had PCI deferred based on their FFR continued to have favorable outcomes for up to 5 years. This provided long-term reassurance that deferring intervention based on FFR is a safe and effective strategy.
So it's a safe bet.
It is.
So FFR helps us make informed decisions for long-term management, which is fantastic.
Absolutely.
Now, there's another measure that's similar to FFR called instantaneous wave-free ratio, or IFR. What's the difference between IFR and FFR, and what are the advantages of using IFR?
Okay, so IFR is like FFR in that it measures the pressure difference across the coronary artery narrowing. But it does so without the need for medication to dilate the coronary artery.
So it's simpler.
It's simpler.
This simplifies the procedure, making it faster and more comfortable for patients.
Absolutely.
That sounds like a win-win.
It is.
And the IFR Sweetheart trial from 2017 directly compared IFR to FFR for guiding PCI decisions.
Okay, IFR Sweetheart.
And what did they find?
So IFR Sweetheart was an important trial because it demonstrated that IFR was non-inferior to FFR in terms of outcomes. Meaning it was just as effective at guiding treatment decisions. And because it doesn't require medication to dilate the arteries, it's a more streamlined and efficient way to assess coronary blockages.
So a simpler approach with comparable results.
Exactly.
And the DEFINE FLAIR trial from 2017 confirmed those findings, showing that IFR was not only non-inferior to FFR, but also led to shorter procedure times and less discomfort for patients.
It's a more patient-friendly option.
So a better experience for the patient.
Absolutely.
DEFINE FLAIR really solidified IFR as a viable and patient-friendly alternative to FFR, particularly in centers equipped with the technology and expertise to perform it.
Right. Not all centers have the capability.
It's a great example of how advancements in technology can improve both patient care and efficiency. Absolutely. Now, how does FFR fare in more complex cases? The SYNTAX-2 trial from 2017 explored the use of FFR in patients with complex coronary artery disease.
SYNTAX-2 complex cases.
So were they just using FFR by itself, or were they using it in conjunction with other things?
So SYNTAX-2 was a fascinating trial. because it looked at how FFR could be integrated with other risk assessment tools in complex coronary artery disease.
Right.
The trial evaluated FFR in conjunction with clinical and anatomical scoring systems to guide treatment decisions,
Right.
and found that this combined approach actually led to improved outcomes compared to the original Syntax trial, which didn't incorporate FFR.
So FFR plus other risk factors.
Right, a multifactorial approach.
So FFR can help personalize treatment even in complex cases.
It can.
And then there's FAME-3, the latest installment in the FAME series published in 2021. This trial went head-to-head comparing FFR-guided PCI to coronary artery bypass grafting, or HABG, in patients with multivessel disease.
No, FB, that was a big one.
So PCI versus CABG.
Head-to-head. FAME-3 was a landmark trial
Okay.
because it provided valuable insights into the optimal revascularization strategy for patients with complex multivessel disease.
Right.
The trial found that CABG was superior to FFR-guided PCI in reducing major adverse cardiac events in these patients.
So CABG won.
In that particular setting, yes.
However, PCI was associated with fewer procedural complications.
It was a less invasive procedure.
So it's all about weighing the risks and benefits.
It is.
This highlighted the limitations of FFR-guided PCI in very complex cases, while confirming its important role in less complex scenarios.
Right. The right tool for the right job.
So it's all about choosing the right procedure for the right patient.
Absolutely.
Speaking of choosing the right approach, let's delve into a topic that often sparks debate in cardiology. Culprit vessel PCI versus multivessel PCI.
Ah, the age-old debate.
What is it all about?
So this refers to the approach taken when a patient presents with a heart attack.
Yeah.
Typically a STEMI, which is a type of heart attack caused by a complete blockage of a coronary artery. The culprit vessel is the artery that's causing the heart attack.
Right, the bad guy.
Exactly. The question is whether to focus only on that culprit vessel during the procedure,
Okay.
or to also address other blockages that might be present in other coronary arteries.
So do you just fix the one that's causing the problem, or do you fix everything?
That's the debate.
It's like deciding whether to fix just the immediate problem or to take a more comprehensive approach.
Exactly.
And the PRIME trial from 2013 provided some valuable early insights into this dilemma.
Okay, PRIME.
So what did PRIME show?
So PRIME compared culprit-only PCI to multivessel PCI during primary PCI for STEMI,
Okay.
and found that performing multivessel PCI,
Yeah.
meaning addressing other blockages at the same time,
Okay.
actually reduced the risk of major adverse cardiovascular events,
Okay.
including repeat heart attacks and the need for urgent revascularization procedures.
So a more aggressive approach could potentially prevent future problems.
Good.
However, the Culprit-Shaw's trial from 2017, which focused on patients with
Culprit shock trial from 2017, which focused on patients with STEMI and cardiogenic shock, a life-threatening condition where the heart isn't pumping enough blood, painted a slightly different picture.
so those really sick patients.
The really sick patients.
Yeah.
Culprit shock found that in these very sick patients, focusing only on the culprit vessel during PCI was associated with better outcomes compared to immediately performing multivessel PCI.
So fixing just the one that's causing the problem.
Right.
Okay.
This suggested that in the setting of cardiogenic shock, a more staged approach might be safer, stabilizing the patient by addressing the culprit lesion first and then potentially addressing other blockages later.
So sometimes a less is more approach is warranted,
It is.
especially in critically ill patients.
Absolutely.
But what about when patients with STEMI are stable? The complete trial from 2019 looked at multivessel PCI in these patients.
Okay, complete
Great.
compared staged multivessel PCI to culprit-only PCI in STEMI patients without cardiogenic shock, and found that the staged approach significantly reduced the risk of both cardiovascular death and repeat heart attack
So it's safer to wait.
in these stable patients, yes.
This provided further support for the concept of addressing other significant blockages, but doing so in a staged fashion after the patient has stabilized from the initial heart attack.
Right, a more planned and deliberate approach.
So timing is key.
It is.
And it seems like FFR might play a role in guiding these decisions as well. The Dynami 3 Primulti trial from 2015 incorporated FFR into the multivessel PCI equation.
Okay, Dynami 3 Primulti.
So how did they use FFR in that trial?
So Dynami 3 Primulti investigated FFR-guided multivessel PCI versus culprit-only PCI in STEMI patients,
Okay.
and found that using FFR to guide the decision of whether to stent other blockages
Okay.
actually reduced the need for repeat revascularization procedures.
Okay, so fewer repeat procedures.
Yeah.
And also lower the risk of major adverse cardiac events,
Better outcomes overall.
all without increasing complications.
Right, a win-win.
This trial really supported the idea of using FFR to personalize the approach to multivessel PCI and STEMI.
It helps to tailor the treatment to the individual patient?
So FFR can help us tailor the treatment to the individual's needs.
Absolutely.
Now, the Compare Acute trial from 2017 took a slightly different approach, evaluating immediate FFR-guided multivessel PCI during the initial procedure for STEMI.
Okay, Compare Acute.
So were they doing everything all at once?
So Compare Acute showed that performing FFR-guided multivessel PCI right away could reduce the need for future revascularization procedures.
Okay, fewer procedures down the road.
Yes.
However, it didn't demonstrate a clear mortality benefit.
No significant impact on mortality.
This trial suggested that while immediate FFR-guided multivessel PCI can be effective in reducing future procedures, the decision of whether to do it right away needs to be made on a case-by-case basis, carefully considering the potential risks and benefits for each individual patient.
Right, a personalized approach.
So weighing the pros and cons is crucial.
It is.
And the Flower and My trial from 2021 further emphasized the importance of patient selection when considering FFR-guided PCI for non-culprit lesions, finding no significant difference in outcomes between FFR-guided and angiography-guided approaches.
So FFR might not always be necessary.
Okay.
It depends on the patient and the clinical situation.
Flower might suggested that FFR might not always be necessary in every case,
Right.
highlighting the need for a nuanced approach to decision-making.
Absolutely.
It's all about finding the right balance.
It is.
All right, it's not a one-size-fits-all approach.
No two patients are the same.
Now, the revived BCI S2 trial from 2022 focused on a specific group of patients, those with ischemic cardiomyopathy and severe left ventricular dysfunction. What did this trial tell us about the role of multivessel PCI in this population?
Okay. Revived BCIS-2.
Okay.
Revived BCIS was an important trial because it challenged the routine use of multivessel PCI in these patients.
Okay.
It found that multivessel PCI didn't actually improve survival or reduce heart failure hospitalizations compared to optimal medical therapy alone.
So medical therapy was just as good.
In this case, yes.
This trial really emphasized the importance of medical therapy as the cornerstone of treatment in this particular group of patients.
Right. Sometimes less is more.
So sometimes less is more.
Absolutely.
And to wrap up our discussion of multivessel PCI, let's revisit the CDL pre-IT trial from 2015. It compared culprit-only PCI to complete revascularization, meaning addressing all significant blockages during primary PCI for STEMI.
Okay. CVL-PRI.
And what does CVL-PRI find?
CVL-PI found that complete revascularization did reduce all-cause mortality and the risk of major adverse cardiac events compared to culprit-only PCI.
Okay, so fixing everything was better.
In this trial, yes.
However, it also emphasized the importance of careful patient selection, ensuring that the benefits outweigh the potential risks.
Right, it's not appropriate for every patient.
So it's all about finding that sweet spot between being aggressive enough to prevent future problems and being cautious enough to avoid unnecessary risks.
A delicate balance.
Now let's shift gears and talk about a specific condition that affects a major artery. Left main coronary artery disease.
Left main disease. Okay.
So tell me about this.
So the left main coronary artery is like the grand central station of the heart's blood supply.
Okay.
It's the main pipeline delivering oxygen-rich blood to the left side of the heart.
Yeah.
Which is responsible for pumping blood to the rest of the body.
So it's a big deal.
It is.
When the left main coronary artery is blocked, it's a serious problem that requires prompt and effective treatment.
Absolutely.
It sounds like a major plumbing issue for the heart.
A good analogy.
So what are the options for treating left main coronary artery disease?
So the two main treatment options are PCI with stents and coronary artery bypass grafting or CABG.
Okay, so PCI or CABG.
Right.
PCI involves using a catheter to open up the blocked artery and place a stent to keep it open.
Right, a minimally invasive approach.
While CABG involves creating a detour around the blockage using a healthy blood vessel from elsewhere in the body.
Open heart surgery.
The choice between these two procedures often depends on the complexity of the blockage and the overall health of the patient.
Absolutely.
It sounds like a complex decision.
It can be.
And I imagine there have been quite a few trials comparing these two approaches.
There have been many trials.
One of the most influential trials in this area was the Syntax trial, published in 2009. It was a massive study that compared PCI to CABG in patients with multivessel disease and left main coronary artery disease. The Syntax trial was a real eye-opener because it found that outcomes were similar between PCI and CABG in patients with left main disease and low or intermediate Syntax scores. However, CABG was actually better for those with high syntax scores.
Syntax, a landmark trial.
What's a syntax score?
So it's a way of assessing the complexity of coronary artery disease
Okay.
based on factors like the number of blockages, their location, and their severity.
Okay, so it gives you a number.
It gives you a score.
The higher the score, the more complex the disease. The syntax trial showed that this score could be a valuable tool in guiding treatment decisions, helping us determine whether PCI or CABG is the better option for a particular patient.
It helps to stratify risks.
So risk stratification is key.
It is.
And it seems like other trials have also explored this PCI versus TPG question in left main coronary artery disease.
There have been many studies.
The pre-combat trial from 2011 focused on a lower risk group of patients with left main disease and found that both PCI and CBG had similar outcomes in terms of major adverse cardiac and cerebrovascular events. This supported the use of PCI as a viable alternative to KG for select individuals with less complex left main disease.
Right, for those who are lower risk.
So expanding the options for those with less severe disease.
Exactly.
And then there's the Excel trial, published in 2016, which also compared PCI using drug-eluting stents to CABG in left main disease with low or intermediate syntax scores.
Okay, Excel found that PCI was non-inferior to CABG
Okay.
for the combined endpoint of death, stroke, or heart attack at 3 years, further supporting PCI as a reasonable alternative to CABG for less complex left main disease,
Okay.
particularly in patients who might prefer a less invasive approach.
So offering patients more choices.
Exactly.
But what about long-term outcomes? The Noble trial, also published in 2016, addressed that very question.
Okay.
So-
Noble. Nobly looked at longer-term outcomes of PCI versus CABG in left main disease
Okay.
and found higher rates of non-procedural myocardial infarction and repeat revascularization with PCI,
Okay.
favoring CABG in terms of long-term durability.
So CABG might be better in the long run.
For some patients, yes.
This trial emphasized the importance of individualized decision-making, taking into account factors like patient preferences, anatomy, and long-term goals.
Right, a personalized approach.
That's not just about short-term results, it's about the long game.
Absolutely.
And the BEST trial from 2015 provided further support for CABG in more complex left main disease, showing better outcomes for major adverse cardiac events, driven by lower rates of repeat revascularization procedures and heart attacks.
Right, so CBG was more durable in those patients.
BEST reinforced the concept that CBG might be the preferred option for more complex left main disease,
Yes.
particularly in patients at higher risk.
For those who are sicker.
It's all about choosing the right tool for the job.
Absolutely.
Absolutely. Now, the Syntax-2 trial, published in 2017, revisited this PCI versus CBG debate, but with a twist.
Okay, Syntax 2. So what was the twist?
So Syntax-2 incorporated newer generation stents
Okay.
and a more multidisciplinary approach to patient selection and treatment,
Okay.
finding that outcomes for PCI actually improved with these advancements.
So PCI was getting better.
It was.
This narrowed the gap between PCI and CG, highlighting the role of technological advancements and the importance of a team-based approach in left main disease management.
Right, a multidisciplinary approach.
It's incredible how technology and collaboration can drive progress.
It is.
Now, the EBC main trial from 2020 focused on a particularly challenging type of left main disease, bifurcation lesions. What makes these lesions so tricky? So bifurcation lesions occur where the left main coronary artery branches into two smaller arteries.
Okay, so it splits.
It does.
These can be challenging to treat with PCI
They can.
because it's difficult to ensure that both branches are adequately stented without compromising blood flow.
Right. You have to be careful not to block off one of the branches.
That's like a 2-for-1 plumbing problem.
Exactly.
What did the EBC main trial tell us about the best approach to treating these complex lesions?
So EBC main compared different PCI strategies for bifurcation lesions
Okay.
and found that a technique called provisional stenting,
Okay.
which involves stenting only one branch initially
Okay.
and then assessing whether the other branch needs a stent.
Okay, so a stepwise approach
Yes.
was associated with better outcomes compared to more complex two-stent techniques.
Right. Sometimes simpler is better.
This trial provided valuable guidance for optimizing PCI techniques in these challenging cases, demonstrating that sometimes a simpler approach can lead to better results.
Less is more.
So sometimes less is more.
It's true.
Now, the Delta Registry published in 2017 wasn't a randomized controlled trial, but it was a large observational study that provided valuable insights into real-world outcomes of PCI and CBG in left main disease.
Okay. Delta reinforced the idea that while PCI can be a good option for some patients with left main disease,
Yeah.
CABG might offer greater longevity,
Okay.
particularly for those with more extensive or complex blockages.
So CABG might be more durable.
It might be.
It highlighted the importance of considering both short-term and long-term outcomes when making treatment decisions.
Absolutely.
It's all about making informed choices.
It is.
Now let's move on to a group of devices that can provide mechanical support to the heart in critical situations. Intra-aortic balloon pumps, or IABPs. What can you tell us about these devices?
So IABPs are fascinating devices.
Okay.
They're essentially balloon-like devices that are inserted into the aorta, the main artery coming out of the heart.
Okay.
They inflate and deflate in sync with the heartbeat, helping to improve blood flow and reduce the workload on the heart. Think of it as giving the heart a little assistance when it's struggling.
It's like a little helper for the heart.
Exactly.
So when are IABPs typically used?
So they've traditionally been used in a variety of situations, including cardiogenic shock,
Yeah.
which is a life-threatening condition where the heart isn't pumping enough blood,
Yeah.
and during high-risk PCI procedures to provide temporary support to the heart.
Okay, so let's talk about some of the trials that have looked at IABPs in these situations. One of the most important trials in this area was IABP SHOCK 2+ in 2012. It evaluated the use of IABPs in patients with cardiogenic shock complicating a heart attack.
Okay, IABP SHOC2,
So,
IABP SHOC was a pivotal trial because it challenged the routine use of IABPs in cardiogenic shock.
good.
The trial found that there was no reduction in 30-day mortality with IABP use compared to medical therapy alone.
So they didn't really help.
Not in terms of survival.
This led to a downgrade in their recommendation and guidelines, suggesting that while they might still have a role in select cases, they're no longer considered a standard therapy for all patients with cardiogenic shock.
Right. Their use became more selective?
So a bit of a paradigm shift.
It was.
Now, the CRISP-AMI trial from 2011 looked at IABP use in patients with a large heart attack but without shock.
Okay, CRISP-AM.
And what did CRISP-AMI show?
CRISP-AM found that using an IABP in these patients didn't actually reduce infarct size, meaning the area of damaged heart muscle, or improve overall clinical outcomes.
So no real benefit there.
Not in that setting.
So using them strategically is key.
Absolutely.
Now, what about high-risk PCI procedures? The BCIS-1 trial from 2010 assessed IABP use in these procedures.
Okay, BCIS-1 showed that IABPs did reduce procedural complications in these patients, but didn't improve long-term mortality.
So they helped during the procedure, but not after that. This suggested that IABPs might be a useful tool for providing temporary support during high-risk procedures, but their benefits might not extend beyond the immediate procedural period.
A bridge to recovery?
So a tool for short-term stabilization, perhaps. Now, the SHOCK trial from 1999, while not specifically focused on IABPs, was a landmark study that compared early revascularization, meaning opening up the blocked artery with medical therapy alone, in patients with cardiogenic shock.
Okay, SHOCK. The SHOCK trial was groundbreaking because it showed that early revascularization significantly reduced mortality in these critically ill patients.
Okay, so opening up the artery was better.
Yes.
However, it didn't specifically address the role of IABPs in this setting.
It was a broader trial.
Okay, so more research was needed to clarify the role of IABPs in cardiogenic shock. The IABP PCI registry, published in 2016, provided some observational data on IABP use in patients undergoing PCI for cardiogenic shock.
Okay. So the IABP PCI registry showed that using an IABP was associated with improved hemodynamics during the procedure, meaning it helped improve blood flow and pressure measurements.
Okay, so it helped with those things.
Yes.
However, it didn't demonstrate a survival benefit.
No impact on mortality.
This further supported the idea that IABPs can provide short-term support, but might not necessarily translate into long-term gains.
Right. Temporary measure.
So they can help stabilize patients during a critical period.
Exactly.
And finally, the IMPRESS trial from 2016 directly compared IABPs to another type of mechanical circulatory support device called Impella in patients with severe cardiogenic shock.
Okay. IMPRESS.
So head-to-head IABP versus Impella.
Head-to-head. IMPRESS was a head-to-head matchup that found no survival benefit with IABPs compared to Impella.
Okay, so no difference in mortality.
Right.
Unfortunately, the overall mortality in this trial remained high in both groups, highlighting the challenges of treating severe cardiogenic shock and emphasizing the need for exploring alternative mechanical circulatory support devices.
Right, we need better options.
So a reminder that we still have much to learn about treating this devastating condition. Speaking of other devices, let's talk about Impella, which, as you mentioned, is another type of mechanical circulatory support device.
Sure.
How does Impella work, and how does it compare to IABPs?
So Impella devices are essentially tiny pumps
Okay.
that are inserted into the left ventricle of the heart.
Okay.
They help to pull blood from the ventricle
No?
and pump it out into the aorta,
Okay, so it's helping the heart pump.
directly enhancing the heart's pumping ability.
That's like a little booster pump for the heart.
It is like that.
And as you mentioned, the IMPRESS trial from 2016 compared Impella to IABPs in severe cardiogenic shock, finding no significant difference in 30-day mortality between the two devices. Are there any other trials that have looked at Impella in this setting?
Yes, there have been a number of other trials evaluating Impella in both cardiogenic shock and high-risk PCI. One of the key trials was PROTECT-2, published in 2012. It compared Impella to IABPs in patients undergoing high-risk PCI procedures and found that Impella did a better job of maintaining hemodynamic stability during the procedure.
Okay.
However, there wasn't a significant reduction in major adverse cardiac events at 30 days.
So again, a short-term benefit, but no long-term benefit.
Right.
So another example of how short-term benefits might not necessarily translate into long-term gains.
Absolutely.
Now, the RECOVER-I trial from 2008 focused on a specific type of cardiogenic shock that caused by a heart attack.
Okay, recover.
That's correct.
I assessed the feasibility and safety of using Impella in these patients
Okay.
and showed that Impella use was feasible
Okay.
and could improve cardiac output without causing any major adverse events.
So it seems safe and effective.
Yes.
This trial laid the groundwork for further research on Impella in heart attack-related cardiogenic shock.
It was a pioneering trial.
And there's another trial called RECOVER-2 that's currently ongoing, right?
Yes, RECOVER-2 is ongoing. It's a large multi-center trial evaluating the clinical outcomes of Impella in both acute decompensated heart failure and cardiogenic shock.
So a bigger trial with hopefully more definitive results.
We're hoping so.
It's one of the most anticipated trials in cardiology because it has the potential to significantly impact how we use Impella in these critical situations.
Absolutely.
So we'll definitely be watching for the results of that trial.
We'll be sure to cover it.
Now, the USPEL registry, published in 2017, provided some real-world data on Impella use in high-risk PCI and cardiogenic shock.
Okay, the USPELA registry showed that Impella use, particularly when deployed early in the course of cardiogenic shock, was associated with reduced in-hospital mortality and improved recovery.
Okay, so early use was better.
It seemed to be.
This highlighted the potential importance of early intervention with Impella to maximize its benefits.
Right. Timing is key.
So timing seems to be critical. And the Detroit Cardiogenic Shock Initiative, published in 2018, also emphasized the importance of early mechanical circulatory support, with Impella showing improved survival rates when Impella was deployed early in patients with cardiogenic shock.
So another study supporting early intervention?
The Detroit Cardiogenic Shock Initiative was a game changer because it really pushed the idea of a more proactive approach to cardiogenic shock management.
Paradigm shift.
It showed that intervening early and aggressively with MCS can make a real difference in outcomes for these critically ill patients.
It can be life-saving.
So a proactive approach can be a lifesaver.
It can.
Now let's take a closer look at Impella in the context of the culprit shock trial. Remember, that trial found that in patients with STEMI and cardiogenic shock, focusing only on the culprit vessel during PCI, was associated with better outcomes compared to immediate multivessel PCI.
Right. And there was a sub-analysis of the culprit shock trial that specifically looked at outcomes with Impella use in those patients. Interestingly, it found that there was no survival benefit with Impella compared to IABP. And Impella was actually associated with higher rates of complications like bleeding in that specific trial population.
So not as good as we thought.
Not in that specific group.
So a bit of a mixed bag. It seems like the decision of whether to use Impella in cardiogenic shock needs to be made on a case-by-case basis, carefully considering individual risk factors and the potential for complications. What are some of the other key differences between Impella and IABPs that clinicians should consider?
So one key difference is the level of hemodynamic support they provide.
Okay.
Impella offers more robust support compared to IABPs, directly enhancing the heart's pumping ability, while IABPs primarily work by reducing afterload.
Okay, so Impella is more powerful.
In a way, yes.
Another difference is the risk of complications.
Right.
Impella is associated with a higher risk of bleeding and vascular complications compared to IABPs.
Yes, that's true.
This is because Impella requires a larger catheter to be inserted into the heart.
Right, a bigger device.
And there's also a higher risk of blood clots forming on the device.
That's a concern.
So Impella can provide more support, but it also comes with a higher risk of complications. Are there any other differences to consider?
Ease of use is another factor.
Okay.
Impella requires more expertise and specialized infrastructure compared to IABPs.
Okay.
Not all centers have the capability to implant and manage Impella devices,
Okay.
while IABPs are generally easier to deploy in most cardiac catheterization labs.
So not as readily available.
Yeah.
So access to specialized care might be a limiting factor for some patients.
It can be.
Now let's move on to two even more advanced mechanical circulatory support devices, tandem heart and ECMO. When are these devices typically used?
So tandem heart and ECMO are usually reserved for the most critically ill patients who aren't responding to other therapies.
So the really sick patients.
The sickest of the sick?
They're often considered last resort options when the heart is failing and other treatments have been exhausted.
Right, when nothing else is working.
So they're like the heavy hitters of mechanical circulatory support.
They are.
Let's start with tandem heart. What exactly is it, and what are some of the key trials that have investigated its use in cardiogenic shock?
So tandem heart is a percutaneous ventricular assist device, or PVAD.
Okay.
It's essentially a pump that's inserted through a catheter into the femoral vein in the groin.
Okay.
The pump then pulls blood from the left ventricle of the heart
Yep.
and pumps it into the femoral artery, bypassing the heart and lungs and delivering oxygenated blood directly to the body.
Wow. So it's completely bypassing the heart.
It is.
It's a remarkable technology that can effectively take over the heart's pumping function.
It's amazing technology.
It sounds like a lifeline for a failing heart.
Yeah.
What are some of the trials that have looked at tandem heart in cardiogenic shock?
So one of the earlier trials was published in 2006
Okay.
and compared tandem heart to IABPs in patients with cardiogenic shock.
Okay.
The trial showed that tandem heart did provide superior hemodynamic support,
Okay.
but it didn't demonstrate a mortality benefit and was actually associated with more complications such as bleeding and limb ischemia or reduced blood flow to the leg.
Oh, so it was riskier.
It was.
So a mixed bag, as with many of these devices. What about other trials?
There was a U.S. tandem heart registry published in 2010 that looked at outcomes with tandem heart use in cardiogenic shock.
Okay.
This registry showed that in carefully selected patients, tandem heart was associated with improved hemodynamics and short-term survival. This highlighted the importance of patient selection to maximize the chances of success and minimize the risk of complications.
So choosing the right patients for tandem heart is crucial.
It is.
Now, another trial assessed the feasibility of using tandem heart during high-risk PCI procedures.
Right.
So,
That trial published in 2013 showed that using tandem heart during these high-risk procedures could improve hemodynamics, helping to stabilize patients during these critical moments.
okay.
However, the trial also emphasized the potential complications associated with tandem heart,
Yeah.
which limited its widespread use in this setting.
So a valuable tool, but not without risks.
Exactly.
Now let's move on to ECMO, which stands for extracorporeal membrane oxygenation. What can you tell us about ECMO, and how is it used in cardiogenic shock?
So ECMO is essentially a form of life support
Yeah.
that involves taking blood out of the body, oxygenating it, and then pumping it back in.
Okay.
It can provide support to both the heart and the lungs,
But
making it a valuable option for patients with severe cardiogenic shock, respiratory failure, or both.
so it's like a heart-lung machine.
It is like that.
It's often used as a bridge to recovery,
Right.
allowing the heart and lungs to rest and heal while the ECMO machine takes over their function.
Giving them time to recover.
It sounds like a last resort therapy, but one that can offer hope in desperate situations.
It is.
What are some of the trials that have looked at ECMO in the setting of cardiogenic shock?
So it's important to note that many of the early trials on ECMO focused on its use in severe acute respiratory distress syndrome, or ARDS, a severe lung condition. However, the findings from these trials can be extrapolated to cardiogenic shock, especially if there's also respiratory failure involved.
That makes sense.
Oh.
So what were some of the key findings from those trials?
One trial called EOLIA, published in 2018, evaluated ECMO in severe ARDs.
Okay.
While it didn't show a significant mortality benefit overall,
Okay.
it suggested that there might be a benefit for carefully selected patients.
Okay.
This trial really emphasized the importance of individualizing treatment decisions and considering the risks and benefits of ECMO on a case-by-case basis. It's not a one-size-fits-all therapy.
Absolutely. Personalized medicine is key.
Huh.
Now, another trial called CAESAR was published back in 2009 and assessed ECMO versus conventional therapy in ARDs.
Oh, okay. Caesar.
So,
This trial did show an improvement in survival with ECMO in patients with severe respiratory failure.
okay.
While it wasn't specifically focused on cardiogenic shock,
Yeah.
the findings did support the use of ECMO in these very sick patients who are often dealing with both heart and lung failure.
So, another piece of the puzzle. Now there's actually a trial that's currently underway called ECMO CS that's specifically looking at ECMO outcomes in heart attack-related cardiogenic shock.
That's right. ECMO CS is ongoing.
So,
It's a highly anticipated trial
yeah.
because it's designed to provide more definitive data on the role of ECMO in this specific population.
Fingers crossed.
We're all eagerly awaiting the results.
Early data from the trial suggests that ECMO might improve survival in carefully selected patients, particularly when it's initiated early in the course of shock.
Right, early intervention is key.
It sounds promising. We'll definitely have to keep our eyes peeled for those results. Now, there was an observational study published in 2014 called SAVE that looked at VA ECMO, which is a specific type of ECMO that provides support to the heart in patients with refractory cardiogenic shock.
Okay, Savvy.
So what is refractory cardiogenic shock?
So refractory cardiogenic shock is a really tough situation.
Okay.
It means the shock isn't responding to other therapies.
Okay, so they've tried everything.
They have
But this SAVE study offered a glimmer of hope.
It did.
It found that even in these extremely sick patients, about 30% survived when supported with VA ECMO.
That's significant.
Wow, that's incredible. It's like a beacon of light in a very dark place. So ECMO can truly be a lifesaver in dire circumstances. Okay, we've covered a lot of ground with mechanical circulatory support devices. It's amazing to see how these technologies have evolved to provide a lifeline for patients with failing hearts.